Alright, in this audio we will pick back up with seizures and epilepsy. Seizures are abnormal, uncontrolled electrical discharge of neurons. Seizures can cause a change of level of consciousness, behavior, and motor or sensory ability. When an individual has multiple seizures, the cause is typically a pathologic condition of the brain. Epilepsy is when an individual has two or more seizures. Epilepsy is a chronic disorder, and it may be caused by an abnormality in electrical neuronal activity, an imbalance of neurotransmitters, or a combination. There are three categories of seizures: generalized, partial, and unclassified. Generalized seizures typically occur in adults. They involve both of the cerebral hemispheres. Tonic-clonic seizures last 2 to 5 minutes. The tonic phase is when there's a stiffening or rigidity of the muscles and immediate loss of consciousness. The clonic phase is when there are jerking of all extremities. The patient may become incontinent of bladder and bowel. Fatigue, acute confusion, and lethargy may last up to an hour after the seizure. Tonic seizures can occur by themselves, and they can last 30 seconds to several minutes. With tonic seizures, a loss of consciousness occurs. Clonic seizures can last several minutes. Clonic seizures cause muscle contractions and relaxation. There are also myoclonic and atonic generalized seizures. Myoclonic seizures consist of brief jerking or stiffening of the extremities that can occur singly or in groups. This seizure lasts for a few seconds. Contractions can be on one side or both sides of the body. Atonic seizures occur happen and there's a sudden loss of muscle tone followed by postictal confusion. Postictal just means after the seizure. Atonic seizures are more resistant to drug therapy. So with generalized seizures, there are three different categories of seizures. One is generalized, partial, and unclassified. Generalized has 5 different subcategories of seizures. There are tonic-clonic seizures, tonic seizures, clonic seizures, myoclonic seizures, and atonic seizures. Partial seizures, the second category of seizures. Partial seizures are also called focal or local seizures. There are 2 subcategories, complex and simple. Complex partial seizures can cause loss of consciousness or cause the patient to black out for 1 to 3 minutes. Automatisms may occur in absence seizures. Automatisms are repetitive movements that the individual is unaware of, such as lip smacking or certain hand movements occurring. In this seizure, the patient is typically unaware of their environment. After the seizure, the patient can experience amnesia. These seizures occur in the temporal lobe, and they can be referred to as temporal lobe seizures. Simple partial seizures are most often seen in adults. The patient does remain conscious. Auras are typically before the seizure. The patient may experience a feeling of deja vu, they may sense a strong smell, or have a sudden onset of pain. Autonomic changes occur, which are changes in heart rate, epigastric discomfort, and skin flushing can occur. The third and final classification of seizures are unclassified. These account for half of all seizure activity. They occur for no known reason, and they do not fit into generalized or partial seizure classes. So when we talk about seizures, they are abnormal, uncontrolled electrical discharges of neurons. Epilepsy is when an individual has 2 or more seizures. So therefore, epilepsy is chronic. Now, there are 3 different categories of seizures. We talked about generalized, partial, and unclassified. It's important to remember that generalized seizures consist of 5 subcategories: tonic-clonic, tonic, clonic, myoclonic, and atonic. It's important to know that the second category of seizures, partial seizures, consist of 2 subcategories: complex partial seizures and simple partial seizures. And the third category of seizures are unclassified seizures. The etiology of seizures: primary or idiopathic epilepsy is typically associated with genetic factors. Secondary seizures can occur from things such as a brain lesion, a tumor, or trauma. Seizures can also be caused by high fever, stroke, head injury, electrolyte disturbances, and acute alcohol withdrawal. For assessment, you want to know how many seizures the patient's having, how long each seizure lasts, and if there's a certain time of the day or night that the seizure occurs, or if the patient is doing any particular activity before the onset of the seizure. You want to ask if there's an aura before the seizure. You want to ask about medications and any head trauma or high fevers, because seizures can result from those. You want to assess any illicit drug history, and you want to ask about strokes and hypertension in the past. There are non-surgical as well as surgical interventions for seizures. Non-surgical interventions include anticonvulsant or anti-epileptic drug therapy. Combinations of different drugs typically work best for seizures. It's important to educate patients that have a history of seizures. We do not want them to take any meds without consulting their doctor. They should wear a medical alert bracelet or necklace. They should be sure that the individuals that surround them on a normal basis know how to help in case a seizure does occur. They should avoid alcohol. It's important to keep a seizure diary. And we should educate the individuals that medications for seizures must not be stopped. Even if the seizures cease, the medicine should not be stopped. There are different things that we can do as far as surgical procedures. Those are on page 862. Vagal nerve stimulation. This is a surgically implanted device into the left chest wall. And generalized seizures, patients that experience generalized seizures are not good candidates for the vagal nerve stimulation because it can result in neurologic deficits. The patient can actually activate the vagal nerve stimulator with a handheld magnet when they experience an aura. And when they place that magnet to their left chest wall, that can stop a seizure from happening. We should observe these patients for hoarseness of the voice, cough, dyspnea, neck pain, or dysphagia. We want to teach these patients to avoid MRIs, microwaves, and shortwave radios. There are also areas of the brain where the electrical activity is occurring, that these areas of the brain can be removed if they're not vital areas for functioning, or if functioning will not be affected. The way that they assess these electrical areas, they have the patient to stop all of their medications and they monitor their electrical activity in the brain before the surgery. Seizure precautions. It's important to know that now you can place a mattress on the floor instead of using side rails. Padded tongue blades should never be inserted into the patient's mouth. For NCLEX, you definitely want to protect your patient. Do not force anything into the patient's mouth. Turn the patient to the side if you can to keep their airway clear. Loosen any restrictive clothing. You can suction oral secretions if needed, as long as you're not restricting the patient. You do not want to restrain the patient, but you can guide their movements as well. You want to record the time the seizure begins and ends. And after the seizure, you need to get a set of vital signs on the patient, perform neural checks, and keep the patient on their side. Lorazepam or diazepam can be given to prevent status epilepticus. Status epilepticus is a medical emergency and is deemed so whenever the seizure lasts longer than 5 minutes or there are repeated seizures over 30 minutes. Establishing an airway is the priority during status epilepticus. That's the priority treatment for this patient. A loading dose of Dilantin is typically given for these patients. Some causes of status epilepticus are sudden withdrawal from drug therapy, infection, acute alcohol or drug withdrawal, head trauma, or metabolic disturbances. In the next audio, I will begin with meningitis.